My name is Dr. Carol Benson. I'm from Brigham and Women's Hospital and Harvard Medical School in Boston, Massachusetts. Today, my lecture topic is entitled Fetal Anomalies of the Genitourinary Tract. I'm going to be discussing anomalies of the fetal genitourinary tract. The kidneys should be assessed on every second and third trimester ultrasound. First, they should be looked for to make sure that they're present. In their absence, there could be renal agenesis. Second, we want to look at their location to make sure they're in the appropriate location to exclude ectopia or other forms of displaced kidneys. We then look at the size and echogenicity of the kidneys, and that is to exclude dysplasia or autosomal recessive polycystic kidney disease. And then lastly, we look at the collecting system of the kidneys to exclude hydronephrosis. The kidneys are located in the renal fossa on either side of the spine. Here you can see the spine on this transverse view of the fetus, and you can see a kidney on one side of the spine in the renal fossa and the other kidney on the contralateral side. The kidneys are typically hypoechoic compared to the surrounding bowel in front of them, and they often have an echogenic capsule. Sometimes the echoes in the middle of the kidney are brighter than the rest of the kidney. That's the renal sinus or collecting system. On longitudinal view, the kidney is reniform in shape. It has hypoechoic areas in the cortex and more increased echogenicity in the central part of the kidney, the renal sinus echoes. Here's a fetus who has a little bit of fluid in the collecting system of each of the kidneys. Again, this is a transverse view of the fetal abdomen. You can see the spine posteriorly casting a shadow, and on either side of the spine we can see a kidney. And within each of these kidneys we see a little bit of fluid. This is fluid in the collecting system, and in this case this is the normal amount of fluid that you might see in the renal collecting system. We can also confirm presence of the kidney by using color Doppler and looking for the arteries and veins that come from the kidney to the aorta and the inferior vena cava. Here you can see a view of the abdominal aorta, and you can see that one renal artery is leaving the aorta extending towards one kidney, and on the other side, just opposite that artery, is an artery to the contralateral kidney. Likewise, in this case up here, you can see the vessels, the aorta, traveling through the abdomen, and you can see the renal arteries on either side. Now, amniotic fluid volume is important for the fetal development, and so it's important to assess the volume of amniotic fluid around the fetus throughout gestation. The volume depends on homeostasis between the renal function of the fetus and the fetus's swallowing and gastrointestinal resorption. So here's just a couple slides showing a fetus drinking the fluid in the amniotic fluid, and here's a fetus replenishing the fluid by urinating into the amniotic cavity, and that's the balance that allows for a normal amount of amniotic fluid. In the absence of renal function, the fetus will not replenish the amniotic fluid, and prolonged severe oligohydramnios will develop. In the presence of prolonged oligohydramnios, the fetus will not develop appropriately. The fetus will develop pulmonary hypoplasia because it will be compressed by the muscle of the uterus because of the absence of the buffer of the amniotic fluid. In addition, the face will be compressed, so the face will be abnormal, and you'll get limb positional anomalies from the severe oligohydramnios. Bilateral renal agenesis is a case where there is no renal function, severe oligohydramnios develops, and on ultrasound we'll look and look and look and be unable to identify any kidneys or a urinary bladder, and that's because they're absent. In these cases, a clue to the absence of the kidneys is that the adrenals are located in a longitudinal orientation parallel to the spine. Unfortunately, for fetuses who do have bilateral renal agenesis, this anomaly is incompatible with life. Here is a fetus who developed without kidneys. There's bilateral renal agenesis. You can see immediately that there is no amniotic fluid around this fetus on either of the views. You can also see on the longitudinal view of the fetus that when we look in the posterior aspect of the abdomen, we see that the adrenal glands both are located parallel to the spine and that there's absence of the kidneys and no urinary bladder could be found in the pelvis. Now, unilateral renal agenesis is a much less severe anomaly. This is completely compatible with a normal life. While the fetus only develops one kidney, that kidney does compensatorily enlarge and develops more tubules than a single kidney would have, and thus the renal function is normal. On ultrasound, we'll have an empty renal fossa. The adrenal gland on the side of the absent kidney will be oriented in a longitudinal direction parallel to the spine, and we can measure the contralateral kidney and see that it is large for gestational age. So here's a case of unilateral renal agenesis. You can see on our transverse view of the back of the fetus, we have the spine and its posterior shadowing, and adjacent to that on the left side we see a normal kidney, but in the right renal fossa we could not identify a kidney. On the longitudinal view of the aorta, we see only a single vessel coming from the aorta at the level of the renal arteries and no renal artery on the other side because of agenesis of that kidney. Looking carefully at the region of the absent kidney in another case, we can see that the left kidney was absent in this case, and we can see that the adrenal gland is located parallel to the spine, oriented in a longitudinal direction. Likewise, on this fetus, when we interrogated the aorta, we saw only a single renal artery that feeds the right kidney because, again, in this case, the left kidney was absent. Now, the kidney can be located somewhere besides in the renal fossa. This is termed renal ectopia, and the most common location for an ectopic kidney is in the pelvis. So if you don't see a kidney up in the renal fossa, do look around throughout the abdomen to see if you can find the kidney somewhere else. If the kidney is not in the pelvis, it could be crossed and fused to the other side. That's called cross-fused ectopia. And sometimes the kidneys are fused across the midline in the lower abdomen and form a horseshoe kidney. So this fetus has a pelvic kidney. You can see looking at the right renal fossa, we have a normal kidney oriented in the proper location, located in the correct place. But when we looked in the left renal fossa in this fetus, we couldn't find it. When we looked more carefully down in the lower abdomen, we found the left kidney located in the left pelvis, adjacent to the urinary bladder. This is another fetus with a pelvic kidney. You can see that we looked down in the pelvis and next to the bladder we identified this kidney, and we also confirmed that this was a kidney by looking at the descending aorta and seeing an aberrant vessel feeding this, what we thought was a pelvic kidney and proved to be a pelvic kidney. This is the renal artery coming off the lower aorta and feeding the pelvic kidney. This fetus has a cross-fused ectopic kidney. I do have a clip to show you how it works, but first I want to get you oriented. This is a transverse view of the fetal abdomen. The spine is located here with shadowing, and you can see one kidney in the renal fossa. There was no kidney in the other renal fossa, but when we looked at the lower pole of the kidney properly located, we saw more renal tissue extending across the midline in front of the aorta and the inferior vena cava. So here you can see on the clip as we slide up and down that there's two kidneys fused together, one in the appropriate location and then one crossing into the midline, fused with the lower pole of this kidney. This fetus has a horseshoe kidney. You can see when we scan the lower abdomen of the fetus, we're quite low as we're at the level of the urinary bladder, and we saw reniform tissue in a U-shaped crossing over in front of the aorta and the inferior vena cava. This kidney was completely fused, located in the lower abdomen. You can see on the clip the reniform tissue crossing in front of the aorta and the inferior vena cava. Now, we often see fluid in the renal collecting system, and so it's important to evaluate this to see if the fetus in fact has hydronephrosis. We diagnose hydronephrosis when we see dilated calyces as well as a dilated renal pelvis, or if the dilated renal pelvis measures 7 millimeters or more at 16 to 20 weeks, or 10 millimeters or more after 20 weeks. Sometimes, though, we see fluid in the kidney that is not as large as I listed up here. And for those cases, rather than discount them and call them normal, we call those possible hydronephrosis. And that's when the dilated renal pelvis measures 4 to 6 millimeters from 16 to 20 weeks, or 5 to 9 millimeters after 20 weeks. It's important to identify these fetuses because about 10% of them will have significant problems after birth from mild either reflux or obstruction. So here's a fetus at 18 weeks gestation. You can see that there's fluid in both of the renal pelvises, in each of the kidneys on either side of the spine. And when we measure the anterior posterior dimension of the renal pelvis, we see that it's 6 millimeters on each side. So this would be classified as possible hydronephrosis for this fetus. This fetus is 32 weeks gestation. You can see again that posterior view of the back of the fetus with the spine here and the shadowing behind it, and we can see that one kidney is dilated to almost 9 millimeters, the other kidney is dilated to 10 millimeters. So this is a case of hydronephrosis that should be followed after birth. The pediatrician should be alerted to this anomaly. This fetus has fairly severe hydronephrosis. You can see that there are marked dilated calyces throughout the kidney, so this is marked ectasis and a definitive diagnosis of hydronephrosis. Hydronephrosis typically should be followed when it's first diagnosed in utero because during gestation it might resolve, but it also might progress to become more severe. So we do tend to follow these to see whether they do resolve, stay the same, or become worse. It's important to follow these, not necessarily through gestation, but at least one time to see whether there is any progression. So here's a fetus who demonstrated progressive hydronephrosis. At 18 weeks gestation, actually the kidneys were normal. You can see a transverse view of the fetal abdomen. In this case, the spine is down on the image, and on either side, the kidneys showed no dilated pelvises on either side. But here the fetus now is at 34 weeks gestation, and you can see that one kidney has a dilated renal pelvis of 9 millimeters. The other kidney, though, has a markedly dilated renal pelvis at 16 millimeters, as well as ectasis. So this had progressed from no hydronephrosis to fairly severe hydronephrosis in the intervening 16 weeks. Now, hydronephrosis can be caused from a number of different reasons. It can result from obstruction at the ureteropelvic junction, and this is something that's seen more commonly in males than female fetuses with a ratio of about 5 to 1. You can also have obstruction at the level of the distal ureter, and this is something we see with primary megaureter. Vesicoureteral reflux causes dilated kidney and ureter, and so we will diagnose that as hydronephrosis. In addition, bladder outlet obstruction with either posterior urethral valves or prune belly syndrome causes hydronephrosis. Notice that these syndromes or problems related to drainage of urine from the kidneys to the bladder are all more common in males than in females, and in particular the last two diagnoses, posterior urethral valves and prune belly syndrome, are seen exclusively in male fetuses. Ureteropelvic junction obstruction is the most common cause of neonatal hydronephrosis. It's a functional obstruction. That is, there's not a web or anything across the ureter. It's just more of a kink that's partial and therefore does allow some urine to pass through. About 30% of fetuses have this in both kidneys. And fortunately, because the obstruction is functional, it rarely develops into a dysplastic kidney. So here's a fetus with bilateral ureteropelvic junction obstruction. You can see on a transverse view of the fetal abdomen, there's fluid in both renal pelvises. It measures 10 millimeters on one side and 9 millimeters on the other. And a longitudinal view of the kidney shows that we have dilated calyces as well. This fetus has fairly severe bilateral ureteropelvic junction obstruction. You can see that there's a marked amount of fluid in each of the renal pelvises, and the measurements as listed here show that the right renal pelvis measured 16 millimeters and the left 23 millimeters. But you'll also notice that the amniotic fluid around this fetus is normal, and that's because the renal function is normal and the fetus is able to make urine, and the bladder is able to empty it and replenish the amniotic fluid. Now, vesicoureteral reflux occurs when there's abnormal insertion of the ureter into the urinary bladder. The reflux allows urine to climb back up from the bladder into the ureter and even into the kidney, and so on ultrasound we'll see hydronephrosis and hydroureter. The differential diagnosis of the findings of hydronephrosis and hydroureter includes primary megaureter. What's the difference? Well, there is no difference in ultrasound findings with primary megaureter when compared to vesicoureteral reflux, but the pathology is very different. With primary megaureter, you have an aperistaltic segment of the distal ureter that does not allow the urine to drain properly from the kidney into the bladder. So here's a fetus who has hydronephrosis and hydroureter on one side. You can see on a view of the kidneys on either side of the spine that there's mild pelvic dilatation on one side and greater dilatation on the other, where the renal pelvis measures 12.5 millimeters. On the side of the larger dilatation, we were able to identify a dilated tortuous ureter extending from the dilated kidney, which is here, to the bladder. And so this was hydronephrosis and hydroureter. And there's no way in utero to know whether this is reflux or primary megaureter. Renal duplication is when the kidney develops with two regions of the collecting system and two ureters that travel down to the bladder. This is more common in females than it is in males. While this can be a normal finding and renal function can be normal, it also can cause problems. Sometimes the upper pole ureter will become obstructed, and it's not uncommon to have reflux into the lower pole ureter. So we identify this in ureter, particularly when there's hydronephrosis in the affected kidney. On ultrasound, a duplicated kidney will have an elongated kidney that measures longer than it should for gestational age. And we may see fluid in the collecting system that is not the same throughout the kidney. We'll have differential hydronephrosis with more fluid in the upper pole than the lower pole. We also may be able to identify an ectopic ureter in the bladder if the upper pole ureter inserts abnormally. So here is a diagram of what renal duplication looks like in the fetus. When there is no obstruction, you can see that the duplicated kidney is longer than the contralateral kidney and that there are two ureters, and typically the upper pole ureter will travel lower into the bladder and insert than the lower pole ureter. Now, if both insertions work properly, you'll have no obstruction and no reflux. And here is a fetus where there's renal duplication that was not a problem for the fetus. You can see that the normal left kidney is much smaller than the enlarged right kidney, which had two small areas of fluid, normal amount of fluid in the region of both parts of the collecting system. When the upper pole of the upper pole ureter is obstructed, you'll get dilated ureter and dilated kidney in the upper pole of it. This is another diagram showing this in a fetus. You can see that the lower pole ureter is normal and inserts appropriately, but the upper pole ureter inserts in an aberrant location such that it doesn't drain into the bladder properly, and so you have dilatation of that ureter as well as dilatation inside the kidney. And here is a fetus with a renal duplication and asymmetric dilatation of the collecting system. You can see that the normal kidney is being measured and it measures 4.1 centimeters. Compare that to the contralateral duplicated kidney, which measures 5.2 centimeters. So we already have a clue that this kidney is different. And when we look closely at the collecting system on the right side, we can see fluid in the lower pole collecting system separate from the fluid in the upper pole, which is more dilated than the lower pole. Looking even more carefully, we were able to identify the dilated ureter that drains the fluid from this collecting system down into the bladder, but in an obstructed location, so there's backup of urine in the ureter and in the upper pole of the kidney. Here's another fetus with renal duplication. You can see an enlarged kidney with duplication of the collecting systems and dilatation only of the upper pole calyces and pelvis and proximal portion of the upper pole ureter. When we got down to the bladder, we were able to identify what's called a ureterocele. This is where that ureter is obstructed because it's not draining properly. It is obstructed at this point with a backup of urine into the ureter and into the upper pole. Now, renal dysplasias occur when there's obstruction of the kidney that leads to damage to the renal parenchyma, and there are two types of renal dysplasia. The first type occurs when the obstruction to the kidney occurs after 10 weeks gestation or when the obstruction to the kidneys is incomplete, and this leads to a dysplastic kidney that may have a thin echogenic renal cortex and may or may not have hydronephrosis. This is very different than the multicystic dysplastic kidneys that develop when there is early obstruction to the kidney that's complete. So if the obstruction to the kidney is incomplete, you may have a thin echogenic kidney, and if obstruction is complete and early in gestation, it'll be a multicystic dysplastic kidney. This fetus has renal dysplasia and hydronephrosis due to bladder outlet obstruction. You can see that both kidneys are markedly dilated with severe hydronephrosis, and you can see that the cortex around the kidney is very thin and very echogenic, and this is a clue that these kidneys can no longer function. On the clip, you get a better idea of how thin and echogenic the cortex is for each of these kidneys. Well, I mentioned earlier that ureteropelvic junction obstruction does not typically lead to renal dysplasia. In a few cases it does, and here's one such case. This is an 18-week fetus who had a normal kidney on one side and a dilated kidney on the other. This kidney had a dilated renal pelvis as well as dilated calyces, so the diagnosis of ureteropelvic junction obstruction was made. When this fetus came back, however, the right kidney was no longer hydronephrosis and no longer normal in size, but had shrunk in size so that there was very thin residual cortex and still dilatation of the central collecting system. As you can see, it was much smaller than the normal left kidney that was not obstructed. When a multicystic dysplastic kidney develops, instead of seeing a kidney in the renal fossa, you see a large multicystic mass. Typically, this is a unilateral process, but when it's bilateral, it is unfortunately incompatible with life because the fetus develops in the absence of renal function and thus cannot replenish the amniotic fluid, so it's surrounded by severe oligohydramnios. Here's an example of a multicystic dysplastic kidney. You can see on the transverse view of the fetal abdomen, you have a normal kidney on one side of the spine, and on the contralateral side, you see a large multicystic mass replacing the normal kidney. This mass contains multiple cysts that do not communicate with each other. On the longitudinal view, you can see that multicystic mass. You can see how it's much bigger than a normal kidney would be and has very little residual parenchyma. Now here's a fetus who developed a multicystic dysplastic kidney from a ureteropelvic junction obstruction. You can see that at 18 weeks gestation, there was a dilated renal pelvis to 6.6 millimeters, and there were dilated calyces, so this was a hydronephrotic kidney. When the patient returned for a 36-week follow-up, the kidney was no longer hydronephrosis, but had been replaced with multiple cysts and almost complete destruction of the renal parenchyma. Autosomal recessive polycystic kidney disease is a disease that affects the kidneys such that there is severe renal failure, and these fetuses may develop hepatic fibrosis. The severity of the disease in utero and shortly after birth depends on the degree of renal involvement. What we see on ultrasound is that we see enlarged echogenic kidneys. Because these kidneys are typically non-functional, there will be severe oligohydramnios, and we are often unable to identify any bladder because there's no urine to fill it. Here's the typical appearance. This is a longitudinal view of the fetal abdomen. You can see that there is no amniotic fluid around this fetus, and on either side of the spine we see markedly enlarged echogenic kidneys. Now they do retain their reniform shape, but they are much more echogenic than you would expect to see and much larger than you would expect to find. This fetus also has autosomal recessive polycystic kidney disease. In this case, you can see some of the tiny cysts in the kidneys. You can see how big each kidney is. You can see that this kidney on this side of the spine extends about halfway across the abdomen. The kidney on the other side extends almost from the back of the abdomen to the front of the abdomen. Notice there are lots of little cysts throughout these kidneys. This fetus also had a cyst in the liver. This is not an uncommon finding in these fetuses. They can have hepatic cysts, splenic cysts, even pancreatic cysts. Now, Megaureter syndrome does have polycystic kidneys, but also has some other anomalies that allow us to detect that this is a syndrome and not just polycystic kidneys. These fetuses also have encephaloceles, they have polydactyly, they often have cardiac anomalies, and as with polycystic kidney disease, they often have liver cysts. They may also often have a cleft palate. So here is a fetus with Megaureter. You can see in the view of the abdomen that the almost entire abdomen is filled with very large echogenic kidneys with cysts. So these are the polycystic kidneys. When we look at the clip through the hand, we can see there's polydactyly with an extra digit on one side. Here's the thumb, here are the forefingers, here's the extra digit. And when we looked in the head, we saw an encephalocele with protrusion of intracranial contents outside of the cranium. Here's another case of Megaureter. You can see the kidneys here are mildly enlarged and quite echogenic. You can see that the hand has 6 digits instead of 5, and the foot does as well, so there's polydactyly involving both the hands and the feet. Now, autosomal dominant polycystic kidney disease typically does not present until someone is an adult, but occasionally we will see indications that a fetus has autosomal dominant polycystic kidney disease. We may see a few cysts. You know that with adults, the findings are hypertension and renal failure and multiple cysts. So some of those findings we might see in utero. We might see enlarged kidneys. We might see a few cysts. But typically these fetuses still have normal renal function, so we'll have normal amniotic fluid and the urinary bladder will be present. So here's a fetus with autosomal dominant polycystic kidney disease. You can see in scanning through the fetal abdomen, the kidneys are extremely echogenic. They're not enlarged and they do retain their reniform shape. On longitudinal view, you can see the echogenic kidneys but normal reniform shape on each side. There also was normal amniotic fluid around this fetus. When we see echogenic kidneys, we don't always know the cause, but we do need to consider the differential diagnosis, which I've listed here. And the differential diagnosis includes obstructive dysplasia, as I showed you with the obstructed hydronephrotic kidneys from posterior urethral valves. Sometimes multicystic dysplastic kidneys look like echogenic kidneys. We also can have echogenic kidneys from genetically inherited renal disease, either autosomal dominant or autosomal recessive polycystic kidney disease. Echogenic kidneys can be seen with some genetic syndromes, such as Perelman or Beckwith-Wiedemann, or Megaureter, as we've discussed. Other causes include nephroblastosis, renal vein thrombosis, some toxic injuries, some infections, such as cytomegalovirus, ischemia, and aneuploidy. So here's a fetus who had an unusual appearing right kidney. You can see the right kidney, and we saw some echogenic areas within the central part of the kidney, as well as increased echogenicity of the cortex. When we interrogated with the Doppler, we discovered that this fetus had renal vein thrombosis that had tracked from the kidney into the inferior vena cava. Renal cysts are uncommon in the fetus, but not unheard of. They can be an isolated finding or an early sign of dysplasia. So here is a fetus who has a renal cyst in the upper pole of the left kidney. Here's the kidney. Here's the small cyst next to in the upper pole of the kidney. You know it's the left kidney because it's posterior to the stomach. And here we see on the clip that it is an isolated cyst, and the rest of the parenchyma appears normal. Here's another fetus with a large renal cyst extending off the lower pole of the right kidney. Here's the kidney, here's the cyst, here is the kidney here longitudinally with the cyst extending off the lower pole. The most common mass to find in the kidney of a fetus is a mesoblastic nephroma. This is a hamartoma. It's not a malignancy. It's more common in male than female fetuses, and it appears as you expect it would, as a mass in the renal fossa taking up some or all of the kidney. Here's a case where the mass completely replaced the kidney. This is a transverse view of the fetal abdomen. The spine is over here, and you can see a well-encapsulated solid mass in the position of the normally placed kidney. This was a mesoblastic nephroma. Because it does retain its renal capsule, surgical excision is fairly simple. Here's another mesoblastic nephroma. You can see on a longitudinal view of the kidney, there's an echogenic mass occupying most of the upper and mid pole of the kidney with a little bit of residual normal renal tissue. Here again, you can see a little bit of residual normal renal tissue. The rest of the kidney is replaced by the solid mass. Here it is on fetal MRI. You can see the large mass occupying most of the left kidney with a little bit of residual renal tissue inferiorly. And here it is a pathology, large mass, little bit of normal tissue. Now, as part of the evaluation of the fetal genitourinary system, it's important to look at the urinary bladder. First, to make sure that it's present. Absence of the urinary bladder would suggest absent renal function, such as bilateral renal agenesis, bilateral multicystic dysplastic kidneys, or autosomal recessive polycystic kidney disease. We also want to look at its size because marked enlargement should raise concern for posterior urethral valves or prune belly syndrome. Normally, we'll be able to see the urinary bladder in the pelvis by the time the fetus reaches the age of about 13 weeks gestation. We certainly should see it on all our second and third trimester ultrasounds. When the bladder is enlarged, we could have posterior urethral valves. This is an anomaly exclusively found in male fetuses, and it is the second most common cause of hydronephrosis after ureteropelvic junction obstruction. Posterior urethral valves prevent the flow of kidney from the bladder to the amniotic space, and thus the urine backs up into the kidneys through the ureters. So the typical ultrasound findings are oligohydramnios because the fetus is unable to urinate, dilated bladder and posterior urethra, and dilated ureters and dilated kidneys. Now, sometimes the urine leaks from the kidney into the peritoneal cavity, and then you'll have urine ascites. This is the typical appearance of posterior urethral valves. You can see a markedly dilated bladder in the lower abdomen of the fetus and a protrusion from the lower bladder, which represents the posterior urethra. If you look closely, you'll see a small echogenic kidney here. This is a dysplastic kidney. This obstruction has led to dysplasia of both kidneys. There's also was oligohydramnios around the fetus. This is a different fetus with similar findings. You can see the markedly dilated bladder filling the lower abdomen. You can see the dilated posterior urethra. And here we can see the dysplastic kidneys. In this case, they have there's urine within the kidneys, so you see hydronephrosis, but you see the thin echogenic cortex around both of these dysplastic kidneys. There are interventions that can be done with posterior urethral valves that can sometimes lead to salvage of the kidneys. We can do this by draining the urine from the bladder and sometimes by putting shunts in the bladder to allow continuous drainage of urine from the bladder into the amniotic space. So here you can see we're initially putting a needle into the fetal bladder because we're going to drain the urine from this dilated bladder. Now, sometimes posterior urethral valves will present late in gestation. Here is such a case. At 20 weeks gestation, there was normal amniotic fluid, normal sized urinary bladder, and the kidneys had no hydronephrosis. But this fetus returned 10 weeks later at 30 weeks gestation and now had a dilated urinary bladder, oligohydramnios, and hydronephrosis in both of the kidneys. Now, with late presentation, the prognosis is much better. There is a chance that we can preserve the renal function in these kidneys by relieving the obstruction in the bladder or by delivering the fetus and having surgical removal of the obstruction. So in this case, what we did is we drained the urine from the bladder to help drain the kidneys and see whether it would recur or whether we could at least decompress the kidney to buy the fetus a few more weeks in utero. Prune belly syndrome is another cause of dilated bladder and urinary obstruction. This occurs in male fetuses and leads to absence of the abdominal musculature and very abnormal smooth muscle throughout. On ultrasound, we'll see dilated bladder, just like posterior urethral valves. We'll see hydronephrosis, hydroureter. We might even see a dilated urethra in the penis. The difference, though, between prune belly syndrome and posterior urethral valves is that the amniotic fluid volume can be normal. And that's because although these fetuses have obstruction, the obstruction to the bladder outlet is not complete, and so the amniotic fluid can be replenished. So here's a fetus with prune belly syndrome. You can see the kidneys are markedly dilated. They both have mildly echogenic cortex. You can see the bladder is very large with a very large dilated posterior urethra, but there was still amniotic fluid around this fetus. This is a view of the penis of the fetus. Notice that there is urine filling the penile urethra, as we can see it here. As with the posterior urethral valves, we do want to confirm that the renal function is preserved in these fetuses, so we pass a needle into the urinary bladder and drain the fluid to assess the electrolytes. Here you can see after drainage that the penile urethra has collapsed. It still has fluid in it, but nowhere near as much as prior to our drainage. Now, bladder exstrophy is an unusual anomaly where there is an opening in the lower part of the abdomen and the bladder is exposed to the amniotic cavity. It may be everted or exteriorized. This kind of anomaly is associated with other genitourinary anomalies. On ultrasound, we will have normal kidneys, normal amniotic fluid, but we may not be able to see the bladder because it may be so everted and exteriorized that no fluid will collect into it. And instead we may see a small mass protruding from the anterior abdominal wall. So here is a fetus who has bladder exstrophy. There's normal amniotic fluid. The kidneys appear normal. In fact, the cord insertion appears normal, but just below the cord insertion we see a bulge of soft tissue from the anterior part of the abdomen, and this is the everted bladder protruding from an opening in the anterior abdominal wall. Here is another one with the same diagnosis. You can see in the lower abdomen of the fetus a soft tissue protuberance from a defect in the abdominal wall, and here you can see that fetus at birth with extrusion of the bladder through that defect. Now, as part of the genitourinary tract, we do look at the other structures related to the system, and one of these is that we may see abnormalities of the female fetus when there are ovarian cysts. Ovarian cysts appear as cysts in the lower pelvis of the fetus. They're typically simple, but occasionally they'll be complex if there's torsion or hemorrhage to that cyst. The finding is usually a unilateral cyst adjacent to the urinary bladder. In this case, it was on the right side. We saw a cyst next to the urinary bladder. Here you can see the clip showing the cyst located adjacent to the urinary bladder. It's important when you do see a cyst in the fetus to look at the genitalia to see whether it's a female or male fetus, and then to determine whether the cyst involves the kidneys or some other structures. Here's another ovarian cyst. You can see next to the bladder is a nice round simple cyst, and here with eversion mode on a 3D ultrasound you can see the cyst here next to the urinary bladder. If the ovarian cyst develops torsion or hemorrhage, you'll see echoes inside the cyst. Here is one such case where we saw a small ovarian cyst, and on follow-up scan we now saw layering echoes inside the cyst, likely due to hemorrhage. We also look at the external genitalia. On the female fetus, we should be able to identify the labia, and on the male fetus, we identify the scrotum and the penis. While there are a few anomalies that affect the external genitalia, those that do may be a clue to other anomalies within the fetus. Here are two normal fetuses. On this side, we have a normal female fetus in the 3rd trimester where we see the labia and the clitoris, and on this side, you can see a normal male fetus where we see the penis. And here with 3D, we can see the outline of a female fetus where we see the labia sitting in parallel here, and the male fetus with the penis pointing forward in the region of the genitalia. It's not uncommon in the male fetus to see a little bit of fluid in the scrotum surrounding the testicles, as we see here. These small hydroceles are normal, but large hydroceles may be seen with abnormalities including hydrops. So here you see a little bit of fluid on either side surrounding the scrotal contents. Now, ambiguous genitalia is an abnormal finding. It's associated with a variety of syndromes as well as with bladder exstrophy. It also may be seen with unusual karyotypes, so it is very important for these patients to be counseled and given the opportunity to determine the karyotype of the fetus. So here we see a fetus with ambiguous genitalia. This one did prove to be a male fetus, and the fetus had exstrophy. Notice you'll see what looks like splaying of the scrotum or enlarged labia, and we see a small structure protruding between the two. This is either a small penis with hypoplasia, or it could be an enlarged clitoris. You can't tell from these pictures, and that's why it is important to get the karyotypes. And here's another case of ambiguous genitalia. This was also a male fetus at 23 weeks. You can see that the scrotum is splayed to either side and the penis points downward instead of in its usual location above the fused scrotum. Here on the other 3D picture, again, you can see the splayed scrotum with the penis in an inferior location pointing downward. So I've given you a run through the important structures to be evaluated in the genitourinary system and a clue as to what abnormalities you might be able to find and detect when you do your second and third trimester ultrasounds. Thank you.